microbial resistance, but total resistance, no antibiotic left to treat certain organisms with. At the meeting at the Department of Health, the veterinary people were from all different representations, large animal, small animal, poultry, and so on. And we found it very difficult to agree among ourselves on what appropriate antimicrobial policies were. Unlike our colleagues in human medicine who have only one species to look at, we have all of these different problems associated with it. We also have the issue of the fact that veterinary medicine is much more privatized and is highly commercialized, and therefore there's competition. Competition not only to get the animals to come to your particular practice, but in where those practices choose to send, for example, their lab testing and all of the other referral work that you may do. It's estimated that the great majority of antimicrobial prescribing in first opinion practice is empirical, more than 90% of that. And the statement that you see there is a direct quote from Chris Teal, who is the head of antimicrobial resistance at the Animal and Plant Health Agency. Everyone in the veterinary field needs to be involved in this, but because we don't share data with one another, we don't know what's actually going on. In human medicine, for instance, the Central Public Health Lab collates data which is provided to it from all of the different labs around the country. So they have an idea of where these multi-resistant bacteria are geographically, what their antibiograms are, and so on and so forth. SAVSNet and the University of Liverpool are hoping to collate this kind of data, and I think we should all be encouraged to contribute to that so that we have a better understanding of what's going on. And there is, as I say, this huge gap in the market about what we know and what we don't know that we really do need to fill. So the second question then that I'd like you to consider as you go through is, does it really matter what you do? Do you as an individual think that what you do contributes to this? Can you help to stop the spread of antimicrobial resistance? Or is this something that you don't need to worry about and you can leave it for your colleagues to deal with? And again, we'll come back to that at the end. It's a known fact that an increase in prescribing of antibiotics has led to an increase in the rate at which antimicrobial resistance develops. There's absolutely no question about that. But we could turn that on its head and we could say, if we reduce the number of prescriptions that we write for antibiotics, might we reduce the rate at which antimicrobial resistance develops? Would it be advantageous if we only used drugs that had a narrow spectrum of activity rather than the broad spectrum activity drugs that we're using currently? And should we only prescribe these when we have knowledge that we are dealing with a bacterial infection and not something else? The goal then from this workshop that I was at was to reduce the prescribing of antibiotics by 50% by the year 2050 without any increase in morbidity and mortality. Do you need to prescribe antimicrobials will be a salient question that I'm sure that you all ask each time you see one of your patients, and I'm sure that your chief concern is what's going to happen if I don't. And this is the concern that many of the GPs have, of course. You know that you go along with a sore throat or a respiratory tract infection, you're probably expecting to be given antibiotics. A lot of time they give them to you when you don't need them. So several studies were conducted looking at whether this was something that you could have a watchful waiting period for. In the first study, patients who presented at a GP surgery with upper respiratory tract infection were not given antibiotics and sent away for a period of 48 hours and asked to report back after that time, or sooner if they went downhill, of course. The patients who came back at 48 hours generally had an improvement in their symptoms, did not require antibiotics, thereby saving a huge amount of unnecessary prescribing. A similar study with patients in hospital situation with suspected urinary tract infection were also not prescribed antibiotics, and the lab was encouraged to report the results of its urinalysis, including culture and sensitivity, by 24 hours. In doing so, there was once again a great reduction in the number of unnecessary prescriptions being written. It's not always good news though. In a third study in Scotland, The labs were asked to report microbiology 24 hours a day, 365 days of the year. And I have to say that in my lab, that's what we actually do. This is found to be a great benefit to those clinicians who are working in specialist sectors of veterinary medicine, such as orthopedics and dermatology, who have either vet nurses or themselves working 24 hours a day, 7 days a week, and can change antibiotics if the one that they're using currently is inappropriate. I think that's not the case in much primary care veterinary medicine, and often I think that the reports that we send out aren't looked at until the animal next comes back into the clinic. And that was what the study from Scotland found, that although the reports were going out in a timely fashion, no one was looking at them for 7 days and nothing was happening to them. So, you know, the lab was doing its best, but nothing was being done in terms of treatment. You'd also want to know, how do you know that you're dealing with a bacterial infection and not with something else? And are there any point of care tests or rapid tests that might help you to reach that conclusion and decide, therefore, that as a result, antibiotics would be indicated? So is infection present? And we can identify this using a number of different methods. The direct methods include things such as cytology. So you could take an impression smear from an animal's skin, or you could take a fine needle aspirate, excuse me, stain that, look at it, look for evidence of an inflammatory cell response, or for the type of bacteria that may be present. In doing so, it's likely that you're only going to be able to identify those bacteria as cockle-shaped or rod-shaped, but you won't have any further information from that. If you were to proceed to do a gram stain, of course, you may have some better indication, because you'd know then whether the organism was gram-positive or gram-negative. Because of the innate resistance patterns that are exhibited by organisms according to their gram reaction, you may have a better indication of which antibiotics are more likely to work. Urine sediment exam would be another useful thing to do to see if there's evidence of pyuria or bacteriuria and whether you need to treat according to what the outcome of that is. Like everywhere else in the world, there's been a huge upsurge in molecular technologies, including things like real-time PCR testing. These methodologies look for antigens or proteins or DNA of specific organisms. So really, with those methodologies, it's a case of, is organism X present or isn't it? It won't tell you whether anything else is there. You're specifically looking for one organism and one organism only. There are indirect methods, the most simple of which is a straightforward hemogram. So you would look for evidence of increased or decreased white cell count, whether the cells were neutrophils or lymphocytes, pointing either to a more likelihood of being bacterial versus viral. In human medicine, again, they're looking at the neutrophil to lymphocyte count ratio as an indicator of bacterial infection. So that if there's a higher preponderance of neutrophils than lymphocytes, their suggestion is that it's more likely to be a bacterial infection. Acute phase protein assays, it seems like every human who walks into a hospital these days gets their CRP measured. It's a great test, but it's going to be a great test only if you get your results back within a matter of hours rather than a matter of days, and that's not happening because any request for acute phase protein is sent to one of the specialist labs, and it's going to be days before you get your result back, so it's not going to be a great deal of use. But it would be if you could have it as a point of care test. The acute phase protein is going to differ according to species, of course. So in dogs, we'd be looking for CRP, in cats, acid alpha-1 glycoprotein, and in horses, fibrinolin and serum amyloid A. Procalcitonin is a very interesting marker at the moment, and again, it's one that's used massively in human medicine. Normal levels of procalcitonin are undetectable at less than 0.01 micrograms per litre, but rise very rapidly in response to bacterial infection, particularly sepsis, but do not rise in response to any other inflammatory condition or to a viral infection. I don't think we've looked at procalcitonin in animals to my knowledge, but it may be something that we could look at down the line. Interleukin-6 and soluble urokinase like pepsinogen activating receptor are modulatory molecules which again are being looked at, and also again only in humans at the current time. So it's a fact that skin disease is the cause of 20 to 25% small animal veterinary consults, and it follows from that then that the great majority of antibiotic treatment is going to be for those kind of conditions. The goals of that successful therapy of the skin or ear disease will be, first of all, to confirm that you are dealing with infection and to identify what bacteria are causing that infection, and from that to select the most appropriate antimicrobial for treatment. You would need to see the patient again to ensure that that treatment has been appropriate and has worked. It's not, I feel, sufficient to call the owner and ask them how Fred's doing, because they're not going to be able to give you the same kind of information that you can get yourself from examining the dog clinically. And you need to, of course, manage and identify any underlying conditions, since most skin or ear disease is going to be related to something like atopy or hypothyroidism or Cushing's, something of that nature. And if you were to diagnose infection based on cytology alone, you would want to know whether empirical treatment is indicated. So you look at the cytology and decide if there is any evidence of an inflammatory response, what kind of organism you may have present, and so on. Then, from that, you would decide what antimicrobial you are going to use. As I said before, the antimicrobial that you might wish to use will differ according to the organism's gram reaction, but you're not going to know that from doing something like Diff-Quick, which I think most people are normally doing. If you had rods on cytology, for instance, I think many people may assume that those are Pseudomonas and treat accordingly. But there's no indication that those rods are Pseudomonas. They could be Corynebacterium or anything else. And the same is true for cocci. If you knew, though, that the rods were gram-positive or gram-negative, you could tailor your antibiotics according to that, since we know the innate resistance pattern of many of those organisms. Having prescribed empirically, you'd want to know whether your choice of antimicrobial was correct. That could only be assessed by re-examination of the patient. And if it's not being correct, then what are you going to do next? So thinking about cytology then, and we'll run quickly through some slides now of what you might expect to see when you're doing this. The predominant inflammatory cell that you're going to see is probably going to be the neutrophil. We all recognize these, the cells on the right-hand side of the image. There are these multi-lobed cell structures. Over on the left-hand side, we can see that the cells in that image are much increased in number, that they're showing evidence of less lobulation, referred to as a left shift commonly. And within the cytoplasm of those cells, we can see lots of bacteria. We can also see some degree of karyohexis and some cytoplasmic changes suggesting that there's toxic activity. Moving on to the kind of organisms that we may expect to see, the most common of which in skin infections are going to be cocci, probably staphylococci. These here are gram-positive cocci. We would assume them to be staph, but we of course have no knowledge that that's what they are unless we have performed culture and sensitivity and identified them. Similarly, rods, and here we have some gram-negative rods. I couldn't identify those as Pseudomonas, Proteus, or anything else, and I'm sure that none of my colleagues will be able to either. So it would not be appropriate to say just because you have rods that those rods are going to be Pseudomonas. Staining with Diff-Quick, as I said before, you can see that this is full of rods, but you've got no idea, again, whether they're gram-positive or gram-negative, and therefore what you may do with them. Higher bacteria includes the genera Streptomyces, Actinomyces, and Nocardia. Looking at this image, you might think that you were dealing with a fungal infection, and that was a whole load of fungal hyphae, and that mistake has been made. This is actually a gram-stained smear from a dog with otitis media, and this is a sample that was taken at otoscopy. This is Nocardia. It's characterized by these long filamentous bacteria which branch, and they show characteristic beading along the structure of the cell wall. treatment of nocardiasis and actinomyces is, of course, much different from the routine therapies that you would use for normal rods, if you like. Mycobacteria are another group of organisms that you may find associated with atypical skin disease, particularly in cats. These tend to stain negatively if you stain them with Diffquick or with gram stain, because the cells have such a thick waxy coat to them, and it requires a specialized Ziehl-Neelsen stain to identify them. We can identify yeasts, the first of which and the most common of which is Malassezia. These have this common snowshoe or peanut-shaped appearance. They can be found in low number as commensals on the skin of animals, or they can be found in higher number, particularly if there's been any recent use of antibiotics. The second yeast, Candida, is much larger in its cell wall structure, more resembling snowmen, I normally refer to them as. This organism is most likely to be present if there's any underlying immunodeficiency, either innate or induced. A characteristic feature of certain members of that genus is their ability to form germ tubes, which are these long structures that you see. They're actually pseudo-hyphae, and again, they can be mistaken for the true hyphae of true fungi. The production of these germ tubes is a means whereby the organism can reproduce sexually rather than the asexual means of budding, which is the most usual method. True fungi, on the other hand, produce the characteristic hyphae that you can see along this part here, and there's an evidence of a macroconidium over on this side there. Another type of fungus that you may see on cytology is Aspergillus. These have these characteristic fruiting heads and would be highly significant if you were to see them, for example, from a bronchoalveolar lavage in an animal that has symptoms of upper respiratory disease. If you were to see these in a skin scrape, they're probably not significant in that situation and represent nothing more than transient carriage of spores. And this, I threw this one in because I had asked the question before of people what they thought it may be, and responses, for the most part, were that it was an ectoparasite of some kind, possibly some variant of Demodex. It's actually Alternaria alternata, which is another saprophytic mold, and these two are being reported as an increased incidence in people who have immunosuppression. And I think with the advent of the more potent immunosuppressive drugs that we're now using, like Apoquel and Atopica, it's likely that we are going to be seeing more dermatophyte-like reactions that involve this particular mold. So what about those of you who do in practice microbiology? I don't know if anyone does, but testing susceptibility of bacteria to antibiotic agents is not simply a case of sticking a disc on a plate and looking to see if there's a zone. It's vitally important that you adhere to the standards of a particular methodology, and there are three agencies which lay down these standards: the British Society for Antimicrobial Chemotherapy, which is the method that I'm currently using, and then two other methods which are more widely used in Europe and in the United States: the European Committee on Antimicrobial Susceptibility Testing and the Clinical and Lab Standards Institute methods. Each of those methods lays down specific guidelines on how to do the test, including the choice of the agar that you use for that test, the concentration of the drug that's in the disc that you use in the antimicrobial susceptibility, the concentration of the bacteria that you use to set up the assay, the conditions under which you incubate that plate, the temperature, the time, and so on, and then the most important part of all, what the zone size means relative to whether you're likely to get clinical response to that antibiotic in vivo, or whether you're not, or whether there's something else you could do, such as using a higher concentration of it. There are many other factors that you have to take into account when reading antimicrobial susceptibility, and we'll look at some of those now. So I'm going to go through 4 case studies now, and you get the chance here to be interactive. I have to stress there is no right and wrong answer. What I'd like you to do is answer the question based on what your current prescribing practice is, and we'll look at that relative to what we might glean from the outcome of cytology and bacterial culture on these organisms. So case number 1 is Pebbles. And Pebbles is a 5-year-old Jack Russell Terrier who presents with generalized pyoderma. She's currently being treated with prednisolone. She has a history of recurrent skin disease, and she's had multiple courses of clindamycin, antirobe, cephalexin, marbofloxacin, and steroids intermittently. She has no underlying disease. And here is Pebbles, and you can see that she has this redness everywhere, quite angry looking skin, not a very happy little pup. So what would you do based only on what I've told you about Pebbles and what you saw of her in that earlier image? Would you prescribe clindamycin or cephalexin or potentiated amoxicillin or a fluoroquinolone, something else, or would you not prescribe? Just keep that in your mind while we go to the next slide. Cytology from Pebbles' skin shows epithelial cells, tons of bacteria, all of which appear to be cocci, no inflammatory cells, not surprising because she's on preds, so it's likely that there's going to be a dampening down of the immune response. That doesn't mean that those organisms are necessarily not significant. So now you could answer your question. Well, actually you can't, because it's not this one. Oh dear. Sorry. Would you prescribe an antibiotic empirically, or would you refer culture and sensitivity out and prescribe while you're waiting for the culture and sensitivity, or would you not prescribe until you got the result of culture and sensitivity? I apologize that you're not going to be able to answer that question because I've not neutralized the thing. So perhaps we could just have a quick show of hands. Who would prescribe empirically? Nobody. Who would perform culture and sensitivity? Okay. Would you prescribe antibiotics while you were waiting for the results of culture and sensitivity? I apologize for that. This one is going to work now. So if you prescribed an antibiotic empirically while you were waiting for the culture and sensitivity to come back, what would you prescribe? First, press number 1 if you would use ampicillin, amoxicillin, or something like Sinulox. Number 2 for a lincosamide like clindamycin. Number 3 if you'd use a first or third generation cephalosporin such as cephalexin or convenia. And number 4 if you'd opt to use a fluoroquinolone. So 64% of you will prescribe a cephalosporin, which isn't unexpected. That is what I thought was going to be the outcome. Bear that in mind. The results now of Pebbles' bacteriology. Heavy growth of a methicillin-resistant coagulase-positive staph, which is likely to be Staph pseudointermedius. We can only identify Staph pseudointermedius as a member of the Staph intermedius group without molecular typing. So if it's being reported out as Staph pseudointermedius, you would have to hope that whichever lab you sent it to has done that molecular typing, otherwise the nomenclature is not exactly correct. And a light growth of Malassezia. So in vitro, from the susceptibility testing, that organism was resistant to all of the antibiotics that are listed here. Trimethoprim with sulfonamides, erythromycin, amoxicillin with clavulanic acid, cephalexin, cefavecin, marbo, enro, fusidic acid, carbenicillin, piperacillin, ticagrelin, ceftazidime, tobramycin, and of course, oxacillin. It appeared to be sensitive to clindamycin, pradofloxacin, doxycycline, gentamicin, amikacin, and imipenem. However, there are some caveats to that antibiogram report. The first of which is that although that organism appeared to be sensitive to clindamycin in vitro and resistant to erythromycin, it had a positive D-test, and we'll come on to that in a minute. And the D-test is the learning exercise from this particular case history. Because that organism has an inducible clindamycin resistance gene, clindamycin is not indicated to treat that animal with, because as soon as it's exposed to it, it's going to develop resistance. The second comment I would make is that although that organism appeared to be sensitive to the newer fluoroquinolone proudafloxacin in Veraflox, it's very likely, in my opinion, that once you expose that organism to Veraflox, there's going to be rapid development of resistance to proudafloxacin. And I've seen this in almost every instance now where that drug has been used when there's already been resistance to the older fluoroquinolones, both in methicillin-resistant staphs and in things like Pseudomonas. So what is the D-test then? The D-test detects the ERM gene in the MLS B and G phenotypes of Staphylococci and also in some strains of Streptococci. Although these organisms may appear to be susceptible to clindamycin, they aren't because of the inducible gene. They would not respond to clindamycin in vivo. And 68% of all the methicillin-sensitive strains of staph that we're seeing at this moment in time have a positive D-test. Unless that D-test is done, you won't detect those organisms and you'll misprescribe. The figures are not published for staph pseudointermediates, but I have no reason to believe that they're anything different from what we're reporting for Staph aureus. Certainly, I probably see a case a day that has a positive D-test in the lab that I work in. Here is the D-test. So you can see that in the antibiotic here we have erythromycin. Up here we have fusidic acid. Huge, nice circular zone to fusidic acid, indicating that the organism is completely susceptible to it. But if you look at the zone between erythromycin and its partner clindamycin to the immediate right, you can see that there's a very sharp demarcation line here, and then the normal circular structure over here, giving this zone a D-shaped appearance, hence the name of the test, and indicating that that gene is present in that organism and therefore that clindamycin would not be effective. So based now on everything that you know about Pebbles, you've seen her clinical appearance, you've seen the cytology for her, you've had your microbiology report back, what would you now do? Would you prescribe clindamycin for her? Proudafloxacin? Hopefully not, because I've given you the information that neither of those is likely to work. Would you give her doxycycline, or might you do something else? Polling is open. So the great majority of you would do something else, which is a very good answer. Doxycycline, however, would be a very good therapy, and doxycycline is an ideal treatment to use for methicillin-resistant staphylococci to which you have proven susceptibility to that drug. So what else could you do? And the logical thing, of course, would be to use a topical skin shampoo. The choices of topical skin shampoo are the ones that are shown in the list here by and large, and the most effective of those has been shown to be chlorhexidine at concentrations of 2 to 4%, preferably in combination with miconazole. So moving on now to case study number 2, Sam. Sam is an 8-year-old German Shepherd with anal gland abscesses and fistulae. This dog is atopic with a history of recurrent anal gland abscess. Been treated in the past with clindamycin, potentiated amoxicillin, enrofloxacin, all of which have been given on more than one occasion. And he's on atopica for his atopy. At the time of presentation, he's been treated with clindamycin. It's the image of Sam's anal gland area. So just thinking for yourself about what you might do, having seen Sam and have a note of his history. Would you prescribe antibiotics listed there, or would you withhold antibiotics? The cytology from that anal gland shows a massive infiltration of neutrophils with left shift, intracellular rods. So based on the presentation and the cytology, would you continue the clindamycin that he was being given at the time that he presented to you? Would you change the antibiotics empirically to something else? Or would you refer culture and sensitivity off and keep off antibiotics until you had the results of that back? And polling is open. So most people, it seems, would hold off on giving antibiotics until they had the results of culture and sensitivity back, which is admirable, but which doesn't really fit with what I see on a daily basis, I have to say. Because the number of cases of dogs with anal gland abscessation that cross my desk on a daily basis where it's been treated with clindamycin, I cannot begin to tell you, it must be close to 100%. Clindamycin, for those of you who were at Sue's talk last month, is not going to be something that's going to be effective in anal gland disease unless it's something that is involving purely an anaerobic component, which is highly unlikely. If you had prescribed an antibiotic empirically, which none of you had, so the question is somewhat irrelevant, what would it have been? Would it have been ampicillin amoxicillin or amoxicillin with clavulanic acid, a cephalosporin or a fluoroquinolone? So pretend you weren't going to do something else. Which of those drugs might you have used? So the great majority, it seems, went for amoxicillin with clavulanic acid, which would be, I think, probably the best choice of anything that you could conceivably use. However, culture results from this dog showed a heavy pure growth of E. coli. That E. coli was resistant to all of the antibiotics listed here, so trimethoprim with sulfonamides. Erythromycin and clindamycin we'd expect it to be resistant to because it's a gram-negative rod, and all gram-negative rods are innately resistant to those two. Resistant to Sinulox, which is the drug that we indicated we would use. Resistant to cephalexin, cefavecin, marbo, enroprado, orbifloxacin. Seems a little bit of an odd choice, but I'll explain that in a minute. Fusidic acid, doxycycline, carbonicillin, piperacillin, ticagrelin, and ceftazidime. Appeared to be sensitive to framicetin, gentamicin, amikacin, tobramycin, imipenem, and polymyxin B. And the comments on that and the learning tool from this case is, first of all, that we report additional sensitivities for isolates from anal sacs because some clinicians find packing those glands with canoral, framicetin and fusidic acid, Surolan, polymyxin B, or Positex, which is the orbifloxacin that I just mentioned, to be of value. However, the strain of E. coli that was isolated proved to be a CTXM type extended spectrum beta-lactamase producing strain. And this is how we detect extended spectrum beta-lactamases in the lab. It's based on the fact that you get augmentation of the zone around third and fourth generation cephalosporins, resulting in the very characteristic bell shape that you get there. You can see that in the middle is the amoxicillin clavulanate, and it's actually the clavulanic component of that drug that is causing that responsiveness. Looking at that, you would say the organism is resistant to amoxicillin with clavulanic acid, and in this case it actually was. However, in many instances, the isolate can be susceptible to amoxiclav, and in those instances I would suggest that you requested from your lab that they do an MIC, because it may be that you can get an adequate MIC and you can treat successfully with amoxiclav. So now, with all of the knowledge that you have about Sam, you've seen his clinical picture, you've done the cytology on him, you've got the microbiology report, what would you do now? Would you prescribe systemic aminoglycosides? The isolate was sensitive to gentamicin and amikacin. Would you prescribe a topical aminoglycoside? So for instance, pack in the glands with Canaural. Would you prescribe a carbamazepine? It was sensitive to imipenem, so it's highly likely it'll be sensitive to all the other carbamazepines. Or would you do something else? So if you could vote. So the great majority said that they would prescribe a topical aminoglycoside, and that is a highly effective treatment. Flushing the glands with Trizoral, for instance, and then packing with Canaural, as those of you who hear Sue's talk last month will have seen, is a highly effective therapy for anal gland disease. The follow-up treatment for Sam was to do exactly as I've just said to you, to flush the sacs and then pack them with Canaural. But in the end, he did have to go to have surgical intervention and anal saculectomy. And as I just said now, it would be very useful in this instance to have measured an MIC to Sinulox, because it is conceivable, even in any SBL-producing strain, that that drug would prove to be effective. Case 3 then, Jake. Jake is a 4-year-old neutered male spaniel who presents with severe otitis externa involving the ear pinny. This dog is also atopic, and he's on treatment with Apoquel, Marbofloxacin, and Cefavecin, which is the component in Convenia, as you know. So think what you would do for Jake. I have 2 images of him. There's the first. You can see that that skin is really greasy, not very nice looking skin at all. And when you look inside the ear, you can see that there's massive inflammation, and there are also those areas of ulceration. So thinking about what you may do with that information that you've got, would you prescribe antibiotics, exactly the same ones as before, or would you withhold on prescribing? And if you were to prescribe empirically, would you prescribe something topically, systemically, or both? Looking at the cytology from this dog's skin, quite a lot of malassezia you can see, rods and cocci, so we have the whole gamut here. So based on what you see of looking at the dog's ears, Jake's ears and Jake's cytology, what would you do? Would you assume those rods to be Pseudomonas and direct empirical treatment towards that? Would you send off and wait for the outcome of culture? Or would you do something else, for example, using a topical ear cleaner? Interesting mix of answers. So, awaiting the outcome of culture and using a topical ear cleaning preparation seem to be the largest number of responses, but again, not what I see from what's happening in practice. Culture and sensitivity results then for this dog shows heavy growth of Corynebacterium oroscanis, heavy growth of Enterococcus faecium, light growth of Pasteurella multicida, and a heavy growth of the malassezia, together with a heavy growth of the Bacteroides. Following anaerobic culture, the Bacteroides will be susceptible to metronidazole and clindamycin, but resistant to penicillin. The important things to keep in mind from this are that not every rod that you see on cytology is going to be Pseudomonas. Not all the rods that you see on cytology are actually going to be gram-negative. They can be gram-positive, as here. And indeed, not all the cocci that you see on cytology are going to be staph, and they might not even be cocci, as we'll see in a second. This is an image stained by Gram of the Corynebacterium oroscanis from this case. Corynebacteria have for many years been a much overlooked organism. Many labs have chosen not to report them, thinking that they have no significance. They do. They're highly significant. They're gram-positive, as I say, and they produce this characteristic morphology which is referred to as Chinese lettering. So if you see that kind of morphology, you can assume that you're going to be dealing with a corynebacterium of some sort. We have here an image of what at first glance might appear to be cocci. They aren't. They're gram-negative. Gram-negative cocci, while there are some, are not particularly common. But a characteristic thing about these organisms, I'm afraid you can't see it very well, but they are actually very short rods that are exhibiting bipolar staining. So the two ends of the cell wall are staining much more intensely than the central portion of the cell body. And that's a characteristic of Pasteurella and of Yersinia. It would be very easy to mistake those for cocci if you didn't have a trained eye, I think. And that might again lead you down the wrong path of empirical treatment, because they're likely to have a different antibiogram than something that is a true gram-positive coccus. The susceptibilities now for those three organisms. So in column 1, we have the Corynebacterium auriscanis. In column 2, the Enterococcus, and in column 3, the Pasteurella. You can see the broad pattern of resistance that this Corynebacterium exhibits, and that is absolutely not untypical of this organism. It's much more resistant than Pseudomonas. It's resistant to all of those fluoroquinolones, and it's resistant to all the beta-lactams. Your choices for this are fairly limited. And once these organisms gain a hold, they can be very difficult to get rid of. Similarly with Enterococci, another organism that has been overlooked for years and which has come to prominence, I think, primarily because of the increased use of cephalosporins. These organisms are innately resistant to cephalosporins. So the use of those antibiotics is likely to select for them and allow them to overgrow in a particular site. There's another organism, Bacillus, which many labs also don't take great stock of. But the problem with that organism is it produces a very potent beta-lactamase. So if that were to be present alongside, say, a staph or an E. coli or something else, which would appear to be susceptible to cephalexin, and therefore that would be your choice of treatment, that Bacillus's beta-lactamase is going to neutralize that drug to such an extent that you'll have no clinical response of the other organisms to the cephalosporin. Pasteurella, on the other hand, is really quite sensitive, and probably that explains why it's there in lower number, because the treatment that was initiated originally is working for it. So the learning tool here is the reporting of intermediate susceptibility. Intermediate susceptibility is normally taken to indicate that an adequate MIC won't be achieved if you administer the drug systemically, though you may get an adequate MIC if you administer topically to an area where you're going to get a very high concentration. And those drugs may be effective in that instance. However, if there has been exposure to them, it could also be an indication of developing resistance, and that's something that you'd have to bear in mind. Enterococci possess these pathways that enable them to circumvent the activity of trimethoprim and sulfonamides. So although they can appear susceptible to those drugs in the antimicrobial susceptibility test, the use of them clinically isn't recommended because they won't respond. As I say, they're also innately resistant to clindamycin and the cephalosporins, and those drugs will select for them. And we've already talked about the intermediate susceptibility. So based now on everything that you know about Jake, what would you do? Combination of antimicrobials, a topical ear cleaner with an antimicrobial, or just a topical ear cleaner? So the great majority would use a topical ear cleaner alongside an antimicrobial, which I think is probably very appropriate for treating in this case. What else could you do? As I said, topical ear cleaner, and these are the ones that are going to be most useful from the studies that have been reported in the literature, some of which the lab at CAPL has published. So otidine, epiotic, malacetic otic, sanserum, tris with ketoconazole would be highly effective because of the malazetia component that's involved here. Positex has also been shown to be highly effective. The efficacy here perhaps is coming from the very good steroid that's in there and the very good antimycotic in the form of the posaconazole. Moving on then to case 4, Maddie. Maddie is an 11-month-old Labrador retriever who presents with an acute onset of head tilt and shaking. She's just come back from her holidays where she spent lots of time swimming and having a great time. She has no underlying disease and she has no previous history of anything going on with her. There she is, happy as Larry. So for Maddie, what would you do for her? Give her antibiotics empirically, perform some cytology and then prescribe an antibiotic empirically, send away culture and sensitivity and wait for that to come back before you prescribe, or just use a topical ear cleaner. Most people have gone for the topical ear cleaner. This is one instance in which prescribing empirically probably would be acceptable based on the recommendations that are currently in place, and we'll get to those in a moment. So if you were to prescribe that antibiotic or the ear cleaner, would you prescribe topically, systemically, or both? Most people would prescribe topically, which would be the best choice to do in this instance. Topical antibiotic would be much more relevant than giving potent systemics. If you were one of those people who were going to prescribe systemically, what would you use? A cephalosporin, a fluoroquinolone, Sinulox, or something else? So most people will go for Sinulox. Sinulox would be a relevant choice, but you could have used a cephalosporin in this instance, I would guess. On the other hand, if you were going to prescribe topically, which antibiotic would you give topically? Something like Canoral, framacetin with fusidic acid, Surolan, polymyxin B, a fluoroquinolone such as Marbo, fluoxacin, orbifloxacin, or gentamicin topically in Otamax. Most people would have gone for Canoral, good choice I think. I think in the case of this particular dog, anything is likely to have worked for the simple reason that there's been no previous exposure, that there's no history of recurrent skin disease, no evidence of exposure to multi-resistant bacteria. So you're fairly safe in these instances in using something empirically. So when is it okay to treat empirically? And I would argue that in the great majority of cases, never is the right answer unless the condition is really life-threatening. We need to consider what the monetary cost of prescribing drugs empirically is relative, say, to the cost of a good culture and sensitivity. It costs around £20 to get a culture and sensitivity result with sensitivities to more than 10 antimicrobial agents, comment on the organisms that have been isolated, the relevance of the antibiotics to which they appear to be susceptible or otherwise. Compare that to the cost perhaps of a course of cephalexin and then another course of cephalexin, or some convenia and some more convenia and then switching to something else. It's not only the cost of the drugs that's the problem here, it's the long-term cost of what might happen to the animal that you're treating. that it may develop an infection with a multi-resistant organism, to which then you're going to have a hell of a time trying to clear that up after all those antibiotics that it's been exposed to. And when is it then okay to treat empirically according to the guidelines? Those guidelines state that you can treat empirically in a young animal with uncomplicated and superficial pyoderma with the two provisos, that being that there's been no previous history of repeated courses of antibiotics unless in every single instance of that there's been complete resolution of clinical signs once that course is finished. And also that the animal should not be in contact with another animal or with a human who is known to be themselves infected with or in contact with someone else who's carrying a multi-drug resistant bacterium. And this is, again, I have to emphasize it again, it's very important because of the potent immunosuppressive drugs that we're using nowadays. It's not okay to treat empirically in any case of deep pyoderma, nor in a dog that's been treated with one of those potent immunosuppressives that I just talked about. It's no longer the case that we're using antihistamines and things. We're using some serious drugs now to try and curb those immune responses. It's not okay to treat empirically when there's been multiple repeat courses of antibiotics in the past. For a long time, we believed that we shouldn't prescribe empirically if we saw rods on cytology, though I would argue that the same is absolutely true for cocci because you no longer have any clue what those are. You don't know if they're staph, you don't know if they're methicillin resistant, you don't know if they're enterococci. You've got no idea without doing the culture what you're dealing with. Which antibiotics shouldn't you use? I'm talking here about antibiotics that you shouldn't prescribe empirically. These may be very good antibiotics if you've got proof that the organism is susceptible to them. That said, doxycycline, which I've listed here as a good first choice, may, in many instances, including instances of methicillin-resistant staphs, be it MRSA or MRSP, is a very good choice of antibiotic if you've got susceptibility to it. The macrolides and lincosamides, such as erythromycin and clindamycin, would also be good first choices, provided you knew that you weren't dealing with a gram-negative rod, because as I've already said, gram-negative rods are innately resistant to both of those antibiotics. They'd be great for a potential staph infection, but you have to weigh up, might this staph have a positive D test? Might it not be a staph? Might it be an enterococcus? And so on. The sulfonamides and potentiated sulfonamides like trimethoprim sulfonamide also make good first choices. Talk about first generation cephalosporins such as cephalexin and cefadroxil. These are bactericidal and they're very broad spectrum, and they're often, all too often I think, the empirical drug of choice. I've had cases that cross my desk in which cephalexin has been prescribed repeatedly for 3 months. And you have to think to yourself, at what point in that 3 months did someone think, this isn't working and I need to do something else? And suddenly here we are months down the line, sending in culture and sensitivity. It would have been much cheaper, I think, to do it from the beginning. Ideally, these first generation cephalosporins shouldn't be prescribed unless we know that we've got susceptibility to them because of the incidence of overgrowth by organisms which are going to be resistant, such as methicillin-resistant staphs and enterococci and bacillus, as I mentioned earlier. The third generation cephalosporins, and there was a huge upsurge in the use of these, both in human medicine and in veterinary medicine between 2010 and 2013. And I think that that was in part in the veterinary industry to any length because of the introduction of Convenia. Convenia, as you know, is this one-off subcutaneous injection that has activity for 14 days with a report that you can give a second course. Why you would, if you've had no response to the first course, I don't quite know, but it seems that people do. Cefpodoxime is a once-daily third-generation cephalosporin. We don't use it very much in Europe and the UK, but it's given out like Smarties in the USA. Very good drugs, these two, if owner compliance is a potential problem. If you think that the owner's going to have a problem giving the tablets, for instance, then I suppose it's logical that you want to do the best that you can. But I think that what I've just explained to you should be borne in mind when you're prescribing these. With cefavecin in particular, as it gets to the end of that 14-day period of maximal efficacy, I think that the MIC is probably in many instances not going to be high enough any longer to be of any use whatsoever, and may be contributing to the selection for resistance. And again, that's why I bring up the point of considering overgrowth by those organisms. Fluoroquinolones now. Current thinking is that the use of fluoroquinolones should be reserved for evidence of deep pyoderma involving gram-negative rods to which you have proven susceptibility, and in no other instance should those drugs currently be used. The selection of methicillin-resistant staphylococci is a massive problem with fluoroquinolone use when those drugs are administered in the medium to long term, and resistance to them develops very rapidly in staphylococci. So to recap about all these organisms that we're dealing with, there's a whole list of acronyms. So we have methicillin-resistant Staph aureus, methicillin-resistant Staph pseudintermedius, a whole plethora of methicillin-resistant coagulase-negative staphylococci, which I think many people are sadly overlooking. These are an important group of organisms, and there was a recent call at the Veterinary Dermatology Conference in Krakow for labs to identify methicillin-resistant staphylococci to species level. Extended spectrum beta-lactamase producing coliforms, or ESBLs. Non-extended spectrum beta-lactamase producing, but nevertheless multi-drug resistant coliforms, often because they produce potent AMP-C type beta-lactamases. Carbamazepine resistant Pseudomonas and carbamazepine resistant coliforms. We don't use carbamazepines to any great extent in veterinary medicine. I think I've only seen about 4 cases. In those instances, though, it was administered topically in the form of earwicks. Multi-drug resistant Acinetobacter baumannii, and the 3 strains of enterococci, vancomycin intermediate, vancomycin sensitive, and vancomycin resistant. Because we don't use vancomycin to any great extent in the UK and Europe, we don't have a problem as yet with these, but there is a massive problem with them in the United States, where they're using vancomycin to treat common or garden staph infections. So in summary, although you may have signs that suggest that you have a dog that needs treatment because it has a skin disease, diagnosis should, I would argue must, be confirmed using cytology and, where appropriate, culture and sensitivity. There seems really to be no excuse not to perform cytology because it's completely non-invasive and it's very easy to do. And we shouldn't be prescribing antimicrobials on the basis of our clinical impression alone. Do we then need to be worried? You've probably made your own mind upon this earlier, but the primary reason, as I said right at the onset, for the spread of resistance stems from the overuse of antimicrobials. And this can be through one of 2 pathways. First, inappropriate use of them through the often repeated prescribing of empirical antibiotics that are not going to work and which will lead for the selection of resistant bacteria. Or secondly, through an inappropriate duration of antibiosis. We need to ensure that the drug that we're administering is being given at the correct dose and for the correct period of time, and that there is compliance with the drug being given. Both of those things will contribute greatly to helping prevent the spread of resistance. It's been described by the Chief Medical Officer as a global catastrophe, and it's now on the risk register, as I said at the beginning. So is it scaremongering? I hope you've all come to the conclusion that it isn't. There are few antimicrobials in development, and we really need to conserve the drugs that we currently have available to us. The development of resistance is complex, but the driver for it is the increased use. Increased use equals increased resistance. If we can decrease the use, we might slow the rate at which that resistance is developing. And I think that that really would be my take-home message tonight. So in conclusion then, the prudent use of these drugs is key in helping reduce the incidence of infections that involve these multi-drug resistant bacteria, in preventing the spread and in maintaining the efficacy of the drugs that are currently left available to us. Before prescribing, please consider, do I need to give an antibiotic? And is the antibiotic that I'm giving appropriate to this particular case? And in response to the second question, is this something that I should be concerned about? Then I feel that it is. I think that we all need to play our part in this, and that includes each and every one of us here now. Thank you.